Welcome, everybody. I am Dr. Shannon Dowler. I'm with the Office of Infectious Disease and HIV/AIDS Policy. Thank you for participating today in the third webinar of the Stopping Syphilis HHS Summer Seminar Series. Before we begin, if you're needing any technical assistance, please go into the questions and answers and chat with the meeting host. As a reminder, make sure you mute your microphones. As we hear from our speakers, please feel free to submit questions and answers. We'll go through, our speakers will be addressing your questions and answers in the background as we go along, but also at the end, we'll focus on those most frequently asked questions. There is no bad or wrong question, so please submit your questions to us. We are very happy to hear your questions and what's on your mind today. So once again, I want to thank you for joining us today and for your commitment to stopping syphilis in your communities. This is one of 6 webinars we've been hosting throughout the summer on different syphilis-related topics. Today, we're going to focus on best practices for managing syphilis in correctional facilities. And this was organized by the Equity and Syndemic Subcommittee of the National Syphilis and Congenital Syphilis Syndemic Federal Task Force, which is led by Admiral Rachel Levine, the Assistant Secretary for Health. I think this is a really important topic. If you're like me, you're someone who interacts with the correctional facilities only in as much as maybe you've toured them, or you have patients that come and go from them, or maybe you're deeply embedded in them. Regardless, I think the perspective on this is really important for all of us to have. We're going to be joined today by 3 wonderful speakers who will share their perspectives and expertise on managing syphilis in correctional facilities. Boy, I've got an eager mouse today. It just keeps going forward. First, we're going to hear from Commander Ellen Smith with the Bureau of Prisons, who will discuss syphilis trends, risk factors, and best practices in the Federal Bureau of Prisons. She is an experienced clinician and public health professional with over 14 years of experience in the Federal Bureau of Prisons. She's an adult and women's health nurse practitioner and section chief for the Surveillance and Epidemiology section for the Bureau of Prisons. And with that, I am excited to turn it over to Commander Ellen Smith.
Thank you so much for that introduction, Dr. Dowler. I just wanted to start out my presentation explaining that my camera is off. I am coming to you live from a federal prison today. I know that is highly relatable to our correctional health partners on the call, but I wish that my camera could be on, so apologies for that. Next slide, please. So today I'm going to be talking a bit about syphilis trends, risk factors, and some of our best practices and experiences in the Federal Bureau of Prisons. Next slide. So my disclosure, so this presentation was prepared for informational purposes only. Opinions, views, and content expressed are solely of the content creator and speaker and do not necessarily reflect the view of the FBOP, its affiliates, or employees. Next slide. All right, we wanted to make this interactive and fun for you all, so we're going to start with some interactive polling questions. Next slide. Okay, so question number 1. In which type of correctional system do you currently work? And this is a single choice. You can pick one of these, and there's a last choice if you don't work in a correctional system. All right. Oh, wow. Okay. So 75% of us on the call are actually not in the correctional system. Wow, that's really exciting. We also have a smattering of people from local, state, and a little few people from federal. Well, this is really great. We've got a lot of people who don't currently work in corrections, but maybe have an interest in the area. Excellent. Next slide, please. Okay, poll question number 2. So this one actually may not apply to the vast majority of y'all, but what type of services do you most often provide in the correctional system? You can select one of these, and then again, the last choice is none of the above. All right. Oh, wow, okay. We've got a good mix here. Pretty evenly split, but again, as expected, the majority do not work in the correctional system. I'm so excited about this because correctional systems are really these mini communities, and the vast majority of my patients are going to re-enter the community at some point, and so we're all involved in helping reduce syphilis rates. So next slide, please. We wanted to start off with some terminology, especially for those who aren't as familiar with the correctional setting. So we've got jails on the left side of this chart and prisons on the right to sort of explain the differences. So again, there could be differences in terminology by state. Jails tend to be shorter term stays from patients. It's people awaiting trial, sentencing, or maybe both, typically misdemeanors and run by local counties, although caveat there, that may not be the case everywhere. And then on the right, prisons tend to be longer term facilities. It tends to be people serving their sentences, typically felonies, and run by the state or federal government. We also use a broader term of correctional facility, which encompasses both jails and prisons. Next slide, please. So the mission of my section, Surveillance and Epidemiology, within the Population and Correctional Health branch, is to better understand the adult in custody population and subpopulations among our 121 federal prisons nationwide using data. So I work with an epidemiologist to comb through data to look for trends and analyses that can guide interventions to improve health outcomes and promote health equity within our vulnerable population. Next slide. So I wanted to talk to you guys a bit. I'm setting the scene for detecting a rise in syphilis cases. So my section noticed increased ICD-10 diagnoses for syphilis in our electronic medical record. We also anecdotally saw more case consultation happening with our regional infection prevention and control consultants on more syphilis cases. So we did some background research on community syphilis trends to see if we were an anomaly or if we were part of a larger trend. Next slide, please. All right, interactive polling question number 3. Get your mouses ready. What percentage increase in syphilis cases has the US experienced between 2012 and 2022? And again, you can pick one choice. Next slide. Oh, okay, great. All right, we had a plurality of answers, but it looks like the most common answer was 80%, which is the correct answer, unfortunately. Next slide. So the correct answer, as I mentioned, 80% increase in syphilis cases, and that's in the last 4 years. In 2022, syphilis cases have reached the highest level since the 1950s. We have our big red fire alarm. And this is really, really disheartening, is that there's 10 times more babies born with congenital syphilis in 2022 than in 2012. And congenital syphilis, as we know, can have devastating, devastating effects for these babies. Next slide, please. So this is a great slide to us, brought to us by our CDC partners. And this is looking at reported syphilis cases by sex and sex partners. So what I want to show you all is that cases remain high in the men who have sex with men subpopulation, but we're seeing an increasing share of cases over time among women and men who have sex with women. Next slide. This slide is also looking at syphilis trends. This is over the period of 2013 to 2022. This is really startling. Over the past 10 years, the primary and secondary syphilis rate among women increased 867%. As you can see, it started off around 1 per 100,000 in 2013, and now it's roughly 10 per 100,000 as of 2022. Next slide, please. This is a slide with patients with syphilis who have had prior incarceration history. And I think this slide is really important to show that the cases that we have of syphilis, a lot of them have interaction with the justice system in the past. So as you can see, it's hovering between 20 and 30% of men who have sex with women and had syphilis cases. They have had correctional system involvement in the past, and nearly 20% for women. Men who have sex with men, it's around 5%. But as you can see, if we can make interventions in the correctional system, then we can have huge impacts on community syphilis rates. Next slide, please. So now I'm going to our Federal Bureau of Prisons data. So once we saw this uptick in cases, we did some epi analyses to see what the scope of the problem was within our own federal prison walls. So this is the incidence of syphilis in our own population. And it rose from 1 per thousand population in 2018 to 4 per thousand population in 2022 and 2023. You can see a slight dip in 2020. That's likely just due to the pandemic that we had under diagnosis at that time due to resources and staffing being shunted to pandemic priorities. Next slide, please. So next we wanted to look at average time to screening. How long was it taking us to detect a new case of syphilis? What we found was about 53 days after intake, but many of our facilities were not performing routine screening testing. These facilities were following the guidance that we had at the time from the CDC and the BOP, which was risk-based, and it wasn't at that time based on universal screening. Next slide, please. So we wanted to talk a little bit about the syphilis diagnosis trends over time. So just to say, the field is definitely moving towards this universal screening and moving away from risk factors. But if there are any epi nerds in the house, I wanted to include this slide. So looking at the following subgroups, these groups have had an increasing share of our syphilis diagnoses in the FBOP over the study period. So we saw it among females from 2020 to 2022, AICs that were in that mid-adult range for the same time period, AI and AN AICs from 2020 to 2023, an increasing share of residents from Arizona, Missouri, and New York. And we're seeing more people who have actually completed high school or GED comprising syphilis cases, those with a concurrent STI, and those with immigration offenses. Next slide, please. And I just highlighted this here. So one risk factor that we saw in our analysis was that our patients who had a lower completion of education were comprising a high level of our syphilis cases. But over time, we've actually seen those with a higher level of school education completion with a syphilis diagnosis. All right, one more slide for the epi nerds, and this is just talking about our analysis and odds ratios. So the associations of sex, age group, race, ethnicity, education, offense, and other comorbid infections remain significant at the P05 confidence level. We saw those adults who were young adults were more likely to acquire syphilis than adults over 55. Females were almost 3 times more likely to be diagnosed, although that may have to do with additional screening due to pregnancy. People who identified as AI or AN were almost 2 times more likely than those identified as white to be diagnosed. And I mentioned educational level as being a significant finding as well. And comorbid infections were highest among those with HIV, followed by gonorrhea and chlamydia. Next slide, please. So next, we're going to turn to understanding best practices in correctional syphilis programs, and also just talking to y'all about our experiences in the FBOP. Next slide. So first and foremost, we have worked on changing our clinical guidance and protocols. We're moving to universal opt-out testing for syphilis upon entrance to a new facility. We've also added in current recommendations for additional testing during pregnancy, so at 28 weeks gestation and at delivery. We've been encouraging bundling of other routine tests. So we already have a plan in place for HIV testing and hepatitis testing. We're trying to add a bundle, add to that bundle with syphilis testing. And then finally, we've switched to a reverse testing algorithm through our national laboratory contract. Next slide, please. So spotlight on the reverse testing algorithm. This has been really key for us, but also requires a ton of employee education. So just to review, if you guys aren't familiar, so The conventional testing algorithm, this is sort of how we used to do it, was an RPR test followed by a treponemal test if the RPR was positive. But we are moving to the reverse testing algorithm. We actually switched back in October of 23. And so this looks for the antibodies first. There's the treponemal test followed by the non-treponemal RPR if positive. If there's a discrepancy, then we order a TPPA test as a tiebreaker in a sense to get more information. The reverse testing algorithm is more sensitive, so we're happy about that because we do have such a high prevalence of syphilis in our population, but there are more false positives and more cases where you really have to work through the lab results to understand your patient's status. Next slide, please. So as I mentioned this, I just want to highlight in our experience to share this with you all, there's definitely a need for lab education to the field when you're switching to the reverse testing algorithm. So for instance, in the FBOP, most facilities have to order that follow-up TPPA if it's necessary. It's only automated at 3 of our 121 correctional facilities that have an in-house laboratory. We sent out a memo to the field about that, the necessity of ordering that follow-up TPPA if you have a discrepancy. But recently we found that some of those follow-up tests aren't being ordered. And that's a huge gap for us, could lead to a missed opportunity for treatment. And so we've been doubling down on our new employee education and reporting that we've developed to help address this issue. Next slide, please. We've got our little spirochete here. And one additional consideration on the reverse testing algorithm based on our own experience, I just want to say if your organization is looking at making a similar switch, something that we found helpful is to make the reverse algorithm more prominent among the lab choices. You really want to shunt your clinicians to picking the reverse testing algorithm. The only time that someone would want to order an RPR alone is for the 6, 12, and 24-month follow-up after the positive test when you're following those titers and you're wanting to make sure that you've had treatment success. You don't want to have to repeat that full algorithm again, both in terms of wasted time and money, and potentially you get a new clinician who's also confused about the new reverse testing algorithm. Next slide, please. I also wanted to talk about some pharmacy interventions. And we have a fabulous pharmacist. Our chief pharmacist is Captain Tammy Rodriguez in the FBOP. We have a centralized pharmacy system under her leadership. And having that centralized system allowed for early monitoring of bicillin shortages. And we could also streamline our purchasing of bicillin. So instead of having 121 separate sites doing the purchasing, we had one centralized location. We were also able to direct our prison pharmacies nationwide to check all their expiration dates, and we could divert bicillin to areas with shortages. So actually, we haven't had to resort to other medication choices. We've been able to use our centralized supply. And there's one other thing that I want to mention because we've heard of other correctional agencies having some issues with the 340B funding for treatment. I've heard that that's a challenge. I just want to mention that this is where it's so important to partner with your local health department because they can really help get the patients the treatment that they need. And we've also heard that ACA as well as NCCHC are working on solutions to the problem. So if you have a rep through ACA or NCCHC, they can also probably help you with the 340B funding issues. Next slide, please. Also, the cornerstone of our programming is clinician education. So just wanted to touch on some of the education that we've done to the field. We did a 60-minute webinar in September on syphilis signs and symptoms, the need for universal screening, talking about our switch in testing algorithms. We partnered with the National Network of STD Prevention Training Centers, who are absolutely amazing. I cannot say enough good things about them. Among all the resources that they have includes the ability to link clinicians to SMEs for any confusing syphilis cases. It's through the STDCCN, and you can actually get there on their website. We're going to have, there's a one page of resources and additional information at the end of this webinar that you guys are going to have access to. We also had field calls delivered to over 50 participants to update our quality improvement, infection prevention, and control coordinators on the patterns we were seeing in syphilis cases, as well as our new screening recommendations and testing algorithm. We had another 60-minute educational seminar and then 2 clinical alerts that we got emailed to over 200 FBOP employees nationwide to help raise awareness of syphilis cases in the Federal Bureau of Prisons. Next slide, please. So what are some next steps that we're working on? We have an adult in custody educational campaign. So our adults in custody have access to computers for email purposes. And so we're using these computer screensavers slash electronic bulletins to deliver health education across the FBOP with the potential for over 200,000 views a year because all of our adults in custody have access to that system. So we're planning to post content on the importance of syphilis testing and treatment. We want to raise awareness. We're looking at incorporating messaging to appeal to our most affected subgroups, and we recognize the need for culturally competent language and messaging. Next slide, please. We also have some follow-up analyses. So we want to see how all these quality improvement interventions that we put in place have potentially changed our screening rates, and also, how many cases are we detecting at the end of calendar year 2024? So that's coming up. We want to look at our most vulnerable subpopulations as well as overall, and looking for changes in those subpopulations most affected. For instance, women and also AIAN adults in custody. Next slide, please. Well, thank you all so much for your time.
Thank you so much, Commander Smith. That was fantastic. So much great information. We have 2 speakers left, Dr. Kate Mealy, but first I'm excited to introduce you to Tamina Kinsey. She will discuss considerations regarding testing algorithms for syphilis in correctional facilities. Tamina is a nurse and director of public health at Fort Peck Tribal Health. She's an experienced clinician with over 20 years of nursing experience in different hospital settings in the emergency room and the intensive care unit. And with that, I will turn it over to Tamina. Tamina, your mute did not come off.
Good morning. Sorry about that. I didn't hit it hard enough, I guess. I'm happy to be coming to you from northeastern Montana today. Next slide. So the Fort Peck Reservation is home to the Sioux and Assiniboine tribes. It's about 50 miles wide, 110 miles long, and covers several counties. We're approximately 50 miles from Canada and 50 miles from North Dakota. We're tucked way up in the northeastern corner. Our current user population is around 10,000 individuals, give or take. We have 2 larger communities on the reservation, Wolf Point and Poplar, and we have an IHS clinic and tribal health offices in both of those. They're separated by about 22 miles, and each of them have a very distinct culture in each community. There's also several smaller outlying communities that we take care of. As of October 2023, the Fort Peck Tribal Health Program assumed the Public Health Nursing Program from Indian Health Service. And after working for 20 years at IHS, I moved over and continued as the Director of Public Health. We do all the public health things. We do education, prevention, immunization, pregnancy testing, prenatal education, referrals, STI testing, treatment and investigation, as well as all communicable diseases. We are in the offices, in homes, communities, and now the jails. Next slide. As we all saw, just before COVID, syphilis was beginning to emerge on the reservation. After COVID, it really took off, though, and we had about a 728% increase in cases. However, even more troubling, there was an 1,800% increase in congenital syphilis cases. Next slide. Fort Peck has 1 jail located in Poplar, but it acts as both a jail and a prison, as it does house some more long-term individuals. And although it can house more, it generally is around 60 inmates, both men and women. Healthcare is provided at the jail in part by a tribal health nurse practitioner 2 days a week for only a few hours. Inmates can also be transported to the Indian Health Service and seen by a provider either for medical, optometry, dental, or other departments, but that's dependent on whether or not the jail has staff for transports. Public health nurses go to the jail as needed for testing, treatment, investigations. In the beginning, we did some mass testing, and then now we are just as needed. Next slide. We began point of care testing for those without a previous syphilis diagnosis using these tests. We needed to obtain different samples and use multiple test kits for each patient. Next slide. So now we're using the ChemBio. We began using this and we absolutely love it. As long as they've never had a syphilis diagnosis, we can use this test. Anyone with a previous syphilis diagnosis is automatically excluded for point of care testing, and the labs are drawn for an RPR. A huge bonus to this test is that we no longer have to rely on subjective reading of the test kits. There's a micro reader that reads each test for you and takes the guesswork out of it. It only takes 15 minutes, and during that time, that's when we send them to the lab or we draw their blood for gonorrhea, chlamydia, if we need any kind of Hep C, anything like that. Once the test is read, we can begin treatment, confirmatory testing, and investigations if warranted. These tests are small, very portable, and do not need any special transport temperatures or coolers. We've taken them in the community events, jails, and had zero problems with transporting or using them out in the community. We also have community health workers, CHWs, and they're like a combination of a CNA and a CHR. They're able to do off-site testing and transport the patient then to the PHN if necessary. We use the IHS lab, and before point of care testing, it could take up to 3 weeks to get the results. The patient was usually gone by then, especially if they had been in jail, and we had a difficult time finding many of them once we had a positive test. Now we can begin treatment immediately and complete an investigation at the visit. We also make a plan with them to return for treatment, especially if they're in jail and they're going to get released early. We'll want to make sure we get them back in. I receive the jail. Oh, sorry. Next slide. I received the jail roster. Next slide. I receive the jail roster at least a couple times a week. And we use that to find people we're either looking for or maybe someone we've never tested but could be at risk. Reactive point of care testing initiates additional lab work, treatment, and investigation. We can sometimes complete all 3 doses of treatment before they're released from jail. At a minimum, though, we get the first visit done and we make a plan with them to either come to the public health or meet us somewhere, at least contact us and tell us where they're at. All testing and treatment is documented in the electronic health record as soon as we return to the office. And since lab testing is done through IHS, positive labs are automatically sent to MIDAS, which is the Montana Infectious Disease Information System. And that's where we do our investigations. Next slide. We've learned a lot through this process, and we have made many changes along the way. Of course, each visit is individualized to the patient, so the process is not always the same every time. Corrections has been extremely helpful, although like everyone else, they're short-staffed, which can be challenging for us. We initially wanted to train the jail staff to do point-of-care testing, and they were very happy to do it. However, their turnover rate for staff has been making that pretty difficult. There's also no jail nurse at this time. I'm not sure if we're going to get one of those back. They're very difficult to find. We do offer incentive cards, and they have been really the most helpful. We give $20 gift cards for testing, treatment of STIs and Hep C. I was really surprised at the impact that it had on the stigma. People don't come to us for testing anymore. They don't sneak in the back door and quietly ask for testing. They grab their friends and they say, let's go get a gift card. Even the ones who think they might have an STI are much more likely to come in and say, I'm just here for the gift card. Once they're positive, then they'll usually open up and admit to having symptoms of some kind. We will provide gift cards every 3 months, and then they can get it for syphilis, HIV point of care testing. They can get it for Hep C and gonorrhea and chlamydia, as long as they have not been positive previously. If they have a positive point of care syphilis, of course, we do the RPR. If they have a positive Hep C and they already have a positive quant, we don't do anymore. We refer them to the ECHO program for treatment. And that is also for the jail patients. Gonorrhea and chlamydia still takes up to a week for those results to come through. But by then, we've either treated for symptoms or we've made a plan to get them back in. And we're not so patiently waiting for, excuse me, the gonorrhea and chlamydia rapid tests to become available. Patients can also receive a gift card each treatment. So the first visit is the point of care testing and a treatment. They can get a gift card. Then for each additional treatment, they can get gift cards. However, in the beginning, there were some bugs to work out. Some found out that if they did not keep their appointments and they had to restart treatment, they could get additional gift cards. So now we've changed the process, and as long as they come in every week, they get their gift card. If they don't and they have to restart, they have to wait. We hold their gift cards until they're done with all 3 treatments before we'll give them their gift cards. For those in the jail, we hold their gift cards until they're released. Initially, we had been giving them to the jail and they were putting them with the patient's property, but there were some issues and that became problematic. So now we hold them in our office and they can come pick them up when they get released. We're currently not providing doxy-PEP or HIV PrEP, but we're working on plans to roll that out. We've been focused on testing and congenital syphilis prevention, but understand the idea and support the prevention, of course. We routinely work with community partners on the issues surrounding syphilis and the barriers that exist. Thankfully, we've had a decrease in cases as well as a decrease in congenital cases in the last couple of years. We're now beginning to see more non-primary, non-secondary cases due to the negative point of care testing. A lot of our patients will report no chancre, no problems. And then if they're seen by a nurse practitioner or a provider and they actually look, they'll find a chancre. So it's been difficult to diagnose them correctly. It's a slow process and not one that we've done on our own. I meet with our state epi staff weekly still and discuss confusing cases, hard cases, and get input from them. So it's definitely been difficult. Next slide. Thank you for allowing me to share our journey, and please reach out. My email is at the end of the slides, and you're more than willing to reach out and ask questions.
Thank you, Tamina. That was fantastic on the ground information and insights. So helpful. Really, really, your learnings are going to help all of us. So thank you. Last but not least, I want to introduce you to Dr. Kate Mealy. She's a practicing obstetrician gynecologist and medical officer with CDC's Division of STD Prevention. She's going to talk about special considerations for testing people who are pregnant during incarceration. With that, I'll turn it over to Kate.
Thanks so much, Shanna, and thanks so much, Tamina and Ellen, for your great talks as well. As we get started, I just want to provide a little bit of additional context for all of this information, because as both the federal government employee and an obstetrician gynecologist, I think it's really important that we think about the context of all of the work that we're doing. So just a reminder that, medical mistrust is real and it's a huge problem, in particular in the context of syphilis. And this is in no small part due to the U.S. Public Health Syphilis Study at Tuskegee, which was in operation for 50 years. And during that time, people were not consented and they were not offered treatment, even after penicillin was widely available. And I think that not only was this a terrible human rights violation that negatively impacted the people involved in the study, it continues to have generational impacts on families. And those are important for us to keep in mind in the context of syphilis, in particular when we're talking about any medical care during pregnancy. So with that in mind, let's go ahead and talk a little bit about syphilis in the context of pregnancy. And of course, we'll start by talking about the numbers because I'm CDC and that's what we do best. So let's just orient to this graph really fast. So what this is showing is congenital syphilis cases from 2013 to 2022, and that's what the blue bars are. And you can see over time that the blue bars are increasing in height, which indicates more and more congenital syphilis cases. And then the black line is the amount of primary and secondary syphilis among reproductive age women. And what you can see is that these numbers have increased alongside one another. And in 2022, there were 3,755 cases of congenital syphilis reported in the United States, which I think we can all agree is a failure of our medical system and our public health systems. And the thing that we really worry about a lot in particular is congenital syphilis-related stillbirths and infant deaths. And as you can see, the proportions of stillbirths and infant deaths over time have remained about the same. But as we see more and more congenital syphilis cases, we're seeing more and more stillbirths and infant deaths. And in 2022 alone, we saw 231 stillbirths and 51 infant deaths directly related to syphilis. And this is my last epi slide, but I think it really illustrates the differences in the burden of congenital syphilis by race and ethnicity. As you heard from Tamina, it's a huge problem, in particular among American Indian and Alaska Native populations. And what I want to draw your attention to here is the blue bar at the top, which is our AIAN populations. And in this community, they are seeing 1 in 155 live births are impacted by congenital syphilis. Now, I want us all to sit with that number for a minute and just imagine what it would be like to be in a community where 1 in 155 of your live births is impacted by congenital syphilis. And I think we can all agree that that's pretty mind-blowing and that we all need to do better. And I think that a lot of this does depend on the correctional health system so that we can do better in stopping congenital syphilis and protecting the health of all people in the United States. And that's particularly important because our data also tells us that timely syphilis testing and treatment during pregnancy can prevent almost 90% of cases, and I would argue even more than that. So let's talk a little bit about why we're all here today, just as a reminder. So the complications of untreated syphilis are pretty devastating. So for adults, we're thinking about neurosyphilis, ocular syphilis, and otosyphilis, which can lead to stroke, meningitis, blindness, and hearing loss. And then for congenital syphilis, which is transplacental transmission, that can result in miscarriage, stillbirth, and neonatal death. And then the other thing that a lot of people don't know is that syphilis also leads to increased HIV acquisition and transmission. And this is what early congenital syphilis looks like. So this is when it's diagnosed in kiddos who are under the age of 2, and if left untreated, it can lead to serious complications. But most babies, when they're born, are without symptoms, which is why it's so important to be aware of the test results during pregnancy and for us to prevent this, of course. The common symptoms that we see, if there are symptoms, are big liver, big spleen, jaundice, rash, snuffles, and bone problems. And then there's late congenital syphilis, which happens in kiddos over the age of 2. And this is when this congenital syphilis goes undiagnosed and untreated. And those early congenital syphilis cases is not caught and not treated. And this is the classic things that we maybe heard about in school. So your Hutchinson's triad, which is problems with the eyes, the ears, and the teeth, as well as the skull, long bones, and developmental problems. But the important thing is that all of this can be prevented by diagnosing and treating syphilis prior to pregnancy and by diagnosing and treating syphilis at least 30 days before delivery. And the treatment of syphilis during pregnancy can absolutely treat fetal infection and prevent congenital syphilis, which is why we all need to work together to make that happen. And just for your awareness, ACOG, which is the national body that serves out recommendations for obstetrician gynecologists, updated their recommendation around syphilis in April of 2024. And they're now saying that all people who are pregnant should be tested for syphilis 3 times during every pregnancy. So at the first prenatal care visit, universal rescreening during the 3rd trimester, and at birth. So let's think a little bit more about that. So those are the 3 time points that they issued. And I, so now all pregnant people should be tested for syphilis 3 times during every pregnancy. Some states mandate syphilis testing at different iterations during pregnancy. So it's important to be aware of your local regulations. And then you always need to consider point of care testing, which Tamina went through so beautifully. And I provided OBGYN care at a state prison, and I know that it's so hard to find people if you pop as a positive test off of an intake test, and then it's hard to track them down within the prison setting to get them the treatment that they need. And so I think that in particular for people who are pregnant, it's important to consider point of care testing at intake. And then you can give them empiric treatment immediately when you have them right there in front of you, while also awaiting the traditional or reverse sequence algorithm results to get your true syphilis diagnosis and know your further plan for treatment. And then I would also argue that instead of getting the first test at the first prenatal care visit, you should just get it at the first prenatal encounter. And we know that a lot of people are having congenital syphilis in the context of no prenatal care or scant prenatal care. So this is particularly important. And we also know that pregnancy care deserts is a growing problem. And I want to highlight that in the context of this talk, because I've heard from a lot of my friends who work in correctional healthcare, and their assumption is that people will bridge quickly to prenatal care when they are discharged from a jail or a prison. But we know that that is not the reality for a lot of folks. And for some people, the best medical care they'll get in their entire lives is during their correctional stay. And so we need to be ensuring that not only are they getting the care that they need while they're in correctional facilities, but that we're also bridging them to that care through active handoffs, especially in rural places. And I just wanted to give a quick reminder that people who are pregnant who report a penicillin allergy need to be desensitized and treated with penicillin G-benzathine. That is the only treatment for syphilis during pregnancy. And that's because it's the only treatment that's been shown to be efficacious to treat that fetal infection and prevent congenital syphilis. And just as a further reminder, when you're using penicillin G-benzathine for early syphilis, which is primary, secondary, or early latent syphilis, it just requires 1 shot. So if you are doing your intake point of care testing and you're empirically treating with your 1 shot, you're done. But for patients who have latent syphilis that's late or latent syphilis that's of unknown duration, they need 3 shots. And during pregnancy, the acceptable treatment interval between those shots is 9 days. So it's a little shorter than it would be outside of pregnancy. And I wanted to highlight that for everyone today, especially because I know how difficult it is to actually track people down to get them in for their shots. And then I also want to mention that follow-up and partner testing are critical. And in the context of correctional healthcare, I know this is insurmountable, but it's so important to be partnering with local health departments to make these connections so that you can get this on the books and get this to happen. I think, Tamina also talked about, giving your patients copies of their printouts so they know their diagnosis, they know their treatment when they're leaving the facilities. And that also facilitates partner testing and treatment. And just as a reminder, we're using titers to follow people up after they've been treated for syphilis. You compare to the titer obtained on the first day of treatment, and an adequate response is a 4-fold decrease. You worry about reinfection if there's a 4-fold increase or signs and symptoms. And during pregnancy, I get this question all the time, so I wanted to highlight it for y'all. If you have somebody who's treated for syphilis before 24 weeks gestation, you should repeat their syphilis test after 8 weeks and again at delivery. And if they're treated after 24 weeks gestation, you should just repeat that test at delivery alone, and that's adequate. And follow-up testing outside of pregnancy occurs, it's a little different depending on the stage, but in general, it occurs at 6 months, 12 months, and 24 months. And facilitating the care with the health department so that that testing can happen, as well as partner testing and treatment, is of critical importance. And so this is kind of my summary of the things that we talked about for strategies to address congenital syphilis in correctional facilities. So 1 is opt-out syphilis screening for everyone. 2 is syphilis screening 3 times during every pregnancy at intake, 28 weeks, and at delivery. 3 is considering point of care testing for anyone where follow-up might be an issue. 4 is prioritizing treating people who are pregnant with benzathine penicillin G as needed at your facility. I think, it's important to know that our supply of benzathine G should
I think Kate may have frozen. Sometimes I live in the middle of nowhere and sometimes I freeze. So I'm gonna. Hannah, can you confirm that Kate is frozen for you all?
For me too.
Okay, great. I'll keep on. I will channel Kate. Then point of care testing for anyone that has follow-up challenges, prioritize treating people who are pregnant with benzathine G, penicillin, partner treatment. She already talked about that. And then integrating syphilis education into your programs. And that's sort of perfect timing. She was at the end of her slides, and that takes us to syphilis resources, of which there are many, 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 and there's a great QR code she has that you can scan, or you can just go to these. We'll have the deck available to everybody. I'll show you where that you can find that after this. But I think it is time for our final interactive polling question before we turn things over for questions and answers. I've got a couple clinical cases I'm going to pose, but first, true or false? There is broad availability of benzathine penicillin 2.4 million unit doses, so we can now move away from doxycycline as the treatment in non-pregnant persons. Is that true or is that false? This is not a trick question, and we had it on our last webinar, so if you're coming to all of them, then you're getting the answer right. Let's see, what did people say, Damon? Oh, so better. We're getting better. It is true. So Pfizer has confirmed that they're able to meet all orders for 2.4 million units of benzathine penicillin. You should not be experiencing delays or any difficulties. As a matter of fact, if you are having difficulties accessing that, then we want you to reach out to the CDC's website for shortages. They actually have not gotten any since Pfizer made that announcement in early July. They've not gotten any emails saying that people were unable to access it. So you should be able to get that as much as your heart desires, and so that you can shift away from doxycycline as an alternate treatment at this time. If you are having trouble accessing it for some reason, then we would like you to email that shortages email, which we're going to put in the chat for you so that you can all see it. Okay, and with that, we're going to pivot to a few quick clinical questions, and then we're going to turn to your questions and answers that you put in the chat. So let's see here. Ellen, I'm going to start with you, and I'll ask all our speakers, Ellen, Tamina, and Kate, if you could pop back on screen so we can see you. Well, I guess, Ellen, you can't because, you know, prison. Kate, I hope you're back when I see your smiling face on. Oh, you're back, yay! All right, so I'm going to start with Ellen. Ellen, you've got a 45-year-old uninsured male who also has HIV. He was positive for syphilis and treated appropriately. He's going to be due for a 3-month convalescent titer within a few weeks after his release. So how do you recommend he's able to make sure his records travel with him and he lands with the appropriate provider and gets that 3-month convalescent titer?
Well, this is a very relatable scenario. It's happened to me. I would first off bring my patient down and really explain the importance of getting this follow-up, because he's going to have a lot of competing needs when he discharges, including housing, finding work, reconnecting with family and friends. And it could be easy for this to get sort of lost in the mix. So I want to talk to him about the importance of it. I want to go to my medical records person in my facility and make sure that we have his syphilis testing information so that that can go along with him as he discharges. I'm also going to ask him where he's going to be releasing, what community. And then if it's my local community, I'm aware of our community health centers and STI sliding scale centers where he'll be able to go. And really getting him a phone number can be so important for him to be able to make that appointment for the follow-up titer. Those are some of the important messages I have. One I wanted to add, it's also such a good demonstration of the importance of health department collaboration, because I want to make sure that our health department knows about this case and they're also going to be following up when he releases so that we can make sure that he gets the care he needs.
Fantastic. Thank you. As someone on the outside who often sees people after release and I'm trying to get hold of records, it's really hard. So sending them with the person is really ideal. And if you can do warm handoffs, we love it. It makes life so much better for everybody. So thank you for that. Tamina, you've got a 62-year-old male. He's incarcerated in a local jail that's using point-of-care testing on entrance as routine opt-out testing, but he admits that he has a history of syphilis that was treated over 20 years ago. What should that jail offer for testing?
So we're going to do the RPR. In the interim, we're going to start looking for symptoms. Number one, has he had a chancre? Has he had any other issues? And then we're going to be looking in Midas. We're going to be calling everywhere we can to try to find it. It is very difficult, especially if they've been in a prison, but they got shuffled around a few times. Maybe 20 years ago, he wasn't in prison. It's very difficult. Most often they don't know where they were tested. And that affects your staging. But we're going to pretend that he was appropriately treated until we can prove otherwise. So I would suggest that one of our providers does an exam looking for any kind of chancre or any other issues. Sometimes our providers will do x-rays, things like that, looking for other things also. And then as far as staging, until we get that RPR back, we're not really going to know. He will definitely get if he thinks he's been reinfected, we definitely do a test or a treatment that day. If not, we may wait, especially if we think he's going to be in jail for a little while. And then definitely figure out where he's going when he discharges from the jail in case he does get out of jail. There's several reasons why they might get out before their time. So that would be our most common process for that patient, because it is, I think somebody had asked in the question and to answer, how do we know when they say they've been positive, if they've really been positive? And that is a problem that we run into all the time, especially if they've come from other places and maybe they have VDRLs in Midas instead of RPRs, which is what we use. You can't compare them. You can't use them. They're not one-to-one comparisons. So when someone says they've been positive, we're going to check in our Montana Midas system looking for RPRs. We're going to check for anything with the county. We're going to find out where they have been possibly and maybe call a different state. Otherwise, we're just going to have to go with the information that we have and treat them as we have the information.
Awesome. Thank you, Tamina. And I think also key, and you mentioned this in your presentation, that point of care test isn't going to be a good option. You're going to have, just like you said, you're going to have to go right to the serology testing. Kate, I'm going to pivot to you for a quick question, and then we're going to hit a few of the questions and answers that came in. So you've got a 23-year-old female who's pregnant with no prior prenatal care. She's arrested and expected to stay in the county jail for some foreseeable future. As part of her intake, routine STI testing is performed, and she's positive for syphilis. So yay, testing was performed. We found a pregnant person. Wonderful. But she has a history of an anecdotal penicillin allergy. She says her mom just told her, never take that drug again or it'll kill you. Yeah. What do you recommend as next steps?
Yeah, and I see this all the time, and it's always like a moment, so frustrating. And I think it depends on the gestational age of the person. So if they are pregnant and it's a viable pregnancy, which is anywhere over 22 to 24 weeks, depending on your local setting, you will want to have them get penicillin desensitization in the hospital while they're on a monitor. I think the best answer, of course, is to refer them to an allergist and have them tested and fully evaluated. But the reality is that I have never seen that be successful in a correctional healthcare setting. And so I think that the reality is that if your patient is over 22 weeks gestation, you're probably going to send them to labor and delivery at whatever your hospital is where you send folks for delivery. And you're going to ask them to do penicillin desensitization with treatment for syphilis with penicillin. And if they're a delivering hospital, they will have a protocol for how to do that. If they're under 22 weeks gestation, I think it depends on your local situation. And sometimes you'll have enough time to get them evaluated by an allergist and seen and tested, and allergists are doing more desensitization and allergy testing with an oral dose of penicillin and then kind of watch and see what happens. But I think still probably coming from a correctional facility, your best option is going to be to send them to the local hospital for evaluation. And it just depends on your labor and delivery, if they see folks who are pre-viable, if they're willing to do that. And so it's just a matter of knowing your local situation, having a few contacts in your pocket. I'm assuming that anyone in this group on this call has the phone number of a local infectious disease doc on hand. If you don't, let me know, I can get it for you. And that they can help walk you through what your protocol is based on your local resources.
Great, thank you. And now we're going to do speed rounds for our speakers. If you can take a look at the questions and answers, you might have already answered some in the chat. We want to do sort of final remarks. So if you can address a question or two you saw in the chat and a speed round of final remarks. I will start. Well, since we ended with you, Kate, we'll start with you on this one. Were there any questions that you saw in the chat that you wanted to make sure you answered?
Oh, sure. I thought you were going to pitch to me. I did want to address there was a question about point of care syphilis testing. Oh, here, I'll address this question. So Yomi is asking, could they do skin testing before desensitization to make sure it's a true allergy? They absolutely can. I have just never seen that happen effectively. By the time you get someone referred to allergy testing and then to the hospital, for their actual treatment, if it's needed, it's usually takes months, and you just don't have that runway in the context of pregnancy. So I think that you're always going to end up doing an oral penicillin challenge, especially for patients who are over 22 weeks. But, it's possible in your local setting that you could make it happen. All right, go to the next person.
Great, thanks. Ellen, there's a question in here from Rebecca about the Federal Bureau of Prisons guidance and actions. Does it have any impact on local or state jails? Like if they recommend universal testing, would that trickle down? Can you answer that question?
Yes, it's a great question. So we don't have direct authority over state or local jails and their policies, but I do hope that our experiences and guidance in the federal prison system will lead to others following suit, including universal screening. I know Kate posted the current correctional guidance, and it is currently based on institutional or community prevalence. Based on our analyses, we were able to make an argument that we are seeing syphilis widespread, and I think that's a pretty easy argument to make right now. But if we do have anybody on the call from local or state facilities who's looking to change their policies, please feel free to reach out to me. My email address is going to be up later for Ellen Smith. I'd love to help inform your own efforts with our experiences.
Awesome. Tamino, anything in the questions and answers you wanted to make sure you got to?
So I guess one of the things, we do have a policy on people who have an allergy or a stated allergy, because most often it is, well, I had something when I was a child, my mom told me never to take it. So if it has been more than 10 years, we go ahead and treat with penicillin. We review each of the cases with our pharmacy, but most often it was not a true allergy, or it was an allergy to something in the penicillin from years ago. And so we do treat with that. The other issue I did not mention was, for a very short period of time, our tribes had a punitive action for anybody who was not getting treatment. So they were being jailed for not being treated or not getting tested. We have since remedied that. It doesn't bode well for getting more testing done or keeping people healthy. So we have fixed that. But there is still that perception out there, especially in those using drugs, that they don't want to come in for testing. They don't want to get, caught for something. It's getting better. And of course, now that we're in the jails, we can tell them, we're not going to call the cops if you come and get tested with us. But that's still an issue. And then there was some questions about rapid testing. And I understand some of them are out there. I don't know how many of them are all would fall under our clear waiver. But we just have not initiated that yet. It has not, our syphilis or our gonorrhea and chlamydia numbers have not climbed to the point where we're ready to add that in yet.
Fantastic. Thank you again to our panelists and the great information, but all of you who attended as well. We really appreciate your participation and all the questions and answers, and just the interest in this. To remind you, our next webinar is coming up next week. It's doxy. We're talking about treatment and prevention. So doxy has become everybody's favorite antibiotic. Lots happening on the doxycycline front besides just rickettsial disease. So this is going to be a really great webinar where you're going to learn about doxy in a lot of different ways. Following that, we're going to have a lovely summary of a syphilis summit and the findings and the insights that they gained from NACHO and the Raven collection. And then our final webinar is going to be future forward, and we're going to have all sorts of interesting content for you in that last webinar. So please make sure you join us and share the word. You can scan this to get access to slide decks from our webinars. There's also in the chat, I saw that the link was put in the chat as well. There's some also other resources there. We are working on getting the recordings of these webinars released so that folks can that miss them can go back and watch them and learn from them in the future. So that's coming. I promise it'll be here soon. And then finally, if you have questions, please send them to us, sti@hhs.gov. If you have shortages, if you're having trouble with getting benzathine, penicillin, or bicillin, please email stdshortages@cdc.gov. They want to know about it. We are not hearing that any of that is a problem anymore. So if that is fake news and you are seeing problems, we definitely want you to email that address and let them know what your situation is. Thank you again to Commander Smith, to Mina, Dr. Mealy. Their contact information is here on this slide as well. Fantastic resources for everybody. Great to spend the hour with you. And with that, I will bid everyone a happy rest of your day.